Hello, everyone. I'm Carrie Cork. I'm a senior staff attorney at the Public Health Law Center. Thank you all for coming to our webinar today, The Other Epidemic, which focuses on the problem of tobacco use among individuals experiencing mental health and substance abuse challenges, and a few of the approaches that states are taking to address this problem. People coping with mental illness or substance abuse are far more likely to use tobacco products than the general population. In light of the current pandemic, it's easy to lose sight of the disproportionate amount of harm tobacco use causes this population. Indeed, it's been described as a neglected epidemic. And tobacco use has continued in mental health and substance treatment facilities throughout the US because of a culture of addiction among many clients and staff. Before I continue, I need to point out this webinar is hosted by the Public Health Law Center, a national nonprofit network of legal centers and attorneys that support public health and commercial tobacco control policy change at the local, state, and national levels. We do this by providing free legal technical assistance to public health advocates and professionals around the US in several ways, through legal research, policy development, implementation, and defense, and a wealth of publications and resources, which are all available on our website, publichealthlawcenter.org. We also do presentations and trainings such as this one. We don't represent clients in court, and we don't lobby. Finally, our organization is committed to the principle that good public health cannot be achieved without addressing health equity. We have a phenomenal lineup of speakers today, all of whom are experts in tobacco use in behavioral health and substance use facilities, as well as the challenges in addressing this problem. Our first speaker is Dr. Joseph Guydish, who is a professor in Department of Medicine at UCSF and also leads the tobacco control program at UCSF's Helen Diller Family Comprehensive Cancer Center. He has decades of experience in the access, delivery, and organization of substance abuse treatment services, as well as work specifically focused on tobacco dependence in addiction treatment. Dr. Guydish will give us an overview of the problem and a few suggestions for states seeking to integrate smoking cessation and prevention into behavioral health and substance use facilities. Our next speaker is Catherine Saucedo, Deputy Director of the Smoking Cessation Leadership Center at UCSF. The center's goal is to increase smoking cessation rates and the number of health professionals who help smokers quit. Among her many jobs at the center, Catherine has helped create dozens of national, state, and county cross-sector partnerships focused on driving tobacco use prevalence down. Catherine will talk about the work in California and what other state coalitions and partnerships are doing to address this problem around the country. Our final speaker is Reba Mathern-Jacobson, who leads the American Lung Association's behavioral health efforts in Minnesota and North Dakota. Reba has over 20 years of experience living and working within behavioral health settings, doing program development and policy. She coordinates the Minnesota-based Lung Mind Alliance, which involves statewide partners to implement strategies to reduce the disparities and impact commercial tobacco use has on people with mental illness and or substance abuse disorders. Reba will talk about the Lung Mind Alliance and what it's doing to reduce tobacco use in Minnesota. So before we begin, I'd like to give you a framework of the scope and complexity of this problem. In the US, approximately 14% of adults smoke, but smoking rates among those with mental health or substance abuse issues far exceed those among the general population. As you can see, 3 in 10 US adults with mental illness smoke, and that rises to 4 in 10 with serious mental illness. 70 to 85% of people with schizophrenia and 50 to 70% of people with bipolar disorder smoke. And for adults with substance use disorders, the rates are even higher. Researchers estimate that anywhere from 49 to 85% of individuals with substance use issues smoke. The majority of individuals who receive behavioral health treatment die from the consequences of tobacco. For example, cancer, heart disease, lung disease, rather than from their mental illness or substance use. So these have been challenging times for those with mental health or substance use issues. And unfortunately, there could be, with the rise of the pandemic and the EVALI and related health concerns, no better time to address tobacco use in behavioral health and substance use facilities. Many clients in treatment for mental health and substance abuse want to quit and are motivated to quit. And yet, fewer than half of behavioral health facilities incorporate tobacco cessation counseling into their work. Interestingly, studies have shown that when tobacco treatment is provided with addiction treatment, there's a 25% increased likelihood of long-term abstinence from alcohol and other drugs. When individuals quit tobacco, their mental health improves and their anxiety, depression, and stress tend to decrease. What's more, a majority of states allow tobacco use on the grounds of mental health and substance use facilities. Unfortunately, if a smoking culture exists in a treatment facility, it's more challenging for clients to quit. So now I'm going to turn the podium over to Dr. Guydish, who will talk in more detail about this problem.
Thank you, Carrie. And thanks everybody for joining us today. Happy to be here and to put a little bit of scaffolding under a couple of comments that Carrie made. I'm just going to acknowledge, this slide is just to acknowledge my funding sources. I have support from some state funders in the state of California, and also to mention that I work with a lot of partners, both state and local, and with a number of substance use treatment provider agencies throughout California on the work I'm about to present. So probably the reason we're all here today and what drives a lot of my own interest is this issue of smoking in behavioral health populations. And this is data, I'm showing here data from 2000 to 2017. It's CDC data on smoking among persons with serious psychological distress. The CDC defines that through a series of about 6 questions that they ask. In the past 30 days, have you felt anxious, nervous, depressed, worthless? And if you answer yes to those questions, or any of those questions, you're designated as serious psychological distress. So you can see that in this population, smoking rates are about 40%. And as Carrie said, if you look at different epidemiological studies, you may find among persons with mental health or mental illness diagnoses, you may find a little bit lower rates. And if you look at particularly persons with schizophrenia, you'll find quite higher rates. But this is a pretty good representation of smoking prevalence among people, at least in mental health populations that probably many of us serve. You can compare it to the US adult population on the bottom line. That's just CDC. You can see the decrease over time down to about 15% nationally now. Of course, it varies by state. But if you can also look at on the top line data for people who have any substance use disorder. So this is from National Survey on Drug Use and Health. And they ask 2 questions. One question is, are you a current smoker? Another question is, have you received any SUD, substance use treatment in the past year? And if you look at that, you can plot it over time. You can see that however you look at this, persons with serious psychological distress or mental health issues tend to smoke at least double the rate of the general population, and people with substance use disorders tend to smoke at 3 to 4 times the rate of the general population. And of course, it's not only the fact that we have high rates of smoking or high density of smoking in these populations, it's the human cost, it's the economic cost, it's the health and morbidity and mortality issues that we think about and that drive me. So this data I'm going to show here is from a study in Oregon a few years ago. They identified everybody. They identified everybody in the state who had received any mental health treatment, who had received any substance use treatment in the yellow line, and who had received both types of treatment, publicly funded treatment. And then they attached that data to their death records for the state. So that about 150,000 death records over a period of about 6 years. And they were able to, and because the death certificate in Oregon has a question, this is not in every state, but in Oregon it has a question for the certifying physician, was this death tobacco related? It's just the physician's call at the time of death based on whatever they know about the patient or the death that they're certifying. So what that means is you can then look at death rates among people who receive different types of services. So if you look at tobacco-related deaths in the general population, it was only about 30%. If you look at tobacco-related deaths in the population of people who receive mental health services in Oregon, it was also about 30%. If you looked at the tobacco-related deaths among people who received substance use treatment, it was over 50%. And for the people who received both types of treatment, it was 45 or so percent. So the first part of this story is that there's this excess morbidity right here among people who received substance use or mental health services. But the second part of the story is when those deaths occur. So in the general population, the deaths occurred as you would expect, although I'm not saying it's a natural cause, but as many natural causes of death will occur less at lower ages and more at higher ages as you get older. And what this is showing in particular is in Oregon, people who were dying of tobacco-related deaths, most of them were dying at higher ages. But you can do the same thing now for the people who received mental health services, and you can see immediately that the deaths are shifting forward. So now we have more deaths among people who receive mental health services from tobacco-related causes at younger ages. And that pattern continues if you look at tobacco-related deaths among people who receive substance use services. So now you're seeing a lot of deaths under age 60. And by the time you look at cases of people who receive both types of services, you can see now the curve here is completely reversed. Instead of having, as in the general population, most of the tobacco-related deaths later in life, you're now having most of the tobacco-related deaths that occur in this population happening earlier. So the point of the slide in this research, I think, is just to show the excess morbidity among people in behavioral health populations that we serve, and also the earlier morbidity, the premature morbidity that's associated with tobacco. And as Carrie said, most of the substance use programs, I know more about substance use programs, I know somewhat about the mental health services. I've studied in California, but also elsewhere. This data is from a literature review, is about 3 years old, but about 40% of programs shown in the literature review said that, yeah, we advise smokers to quit. 30 to 40% said, yeah, we do cessation counseling, and 12 to 25 or 26% said we provide nicotine replacement therapy or other medications. And so you can judge for yourself, but I think in a system where if you have 70 or so percent of the people you serve who are smokers, then you have to ask, is this glass half full or half empty? I mean, are we doing a good job or are we not doing a good job? And I think the reason we're here today and the reason I'm here today is because I think we're not doing a great job. One of the reasons is that there's high rates of smoking among staff, as Carrie also said. So this is a simple plot of about 24 programs where we're able to look at the rate of staff smoking and client smoking in the same programs. So here's at the bottom left is an example of a program where there's 0% staff smoking, about 20% client smoking. And up here is another example where you have about 60% of staff smoking, but 100% of clients smoking. And if you were to draw a line, you could draw a line right through these dots that would look like that. That would be a linear relationship, showing that the more you have staff smoking in a program, the more you have clients smoking in a program. So I'll say a little bit about what we're doing, what's happening in California, and I think Catherine can add some to that. But the California Department of Healthcare Services, that's our licensing authority. They license and regulate 1,900 SUD programs. Those programs serve about 195,000 persons, unique individuals annually. And I think, as I showed in the first graph, about 70% of those clients smoke. So what's interesting to me is that this system reaches about 136 California smokers every year. That's just for our state. But if you were to multiply that out by 3 or 4 years, you get a treatment system which is reaching about 500,000 smokers. Now, the reason that's important to me is that we only have about 3.2 million smokers in California at this time. So through this type of system, through our behavioral health systems, I know that everybody wouldn't quit smoking, but we could be reaching a really substantial proportion of the smokers in probably any given state. And certainly in California. So what's happening in California is we have this California Behavioral Health and Wellness Initiative. The plan has been to recruit 45 residential behavioral health programs over time. They go into an 18-month-long learning collaborative intervention, which Catherine leads and manages. My part of it is not the intervention. My part of it is to learn what happens as a result of the intervention. What is the impact of the intervention? So we take these programs and we conduct baseline data collection. We visit them at 12 months, and then at 18 months, it's an 18-month-long intervention. So it's before and after the intervention, and then once in the middle. And we talk to directors, and we survey staff, and we survey clients. The first thing I want to say about this, there are about 6 programs that have completed the intervention so far. And one of the goals of the intervention is to implement tobacco-free grounds. So the first thing I'm going to point out is that 5 of the 6 programs implemented tobacco-free grounds. So this is just the timeline for the first 18-month intervention with about 6 programs. This is when Catherine started her intervention, but you can see that even before the intervention, 1 program had gone tobacco-free. But by the end of the intervention, 2, 3, 4, 5 of the 6 programs had gone tobacco-free. 1 program did not go tobacco-free. But the first, I just think it's important to just acknowledge that if the goal was for those programs to go tobacco-free, they did go tobacco-free. But there's more, because remember, we were surveying staff and clients and directors. I'll just talk about the clients for a minute. The smoking rate among clients in these 6 programs was 54% at the beginning of the intervention. 18 months later, it was 26%. So it didn't mean that everybody stopped smoking, but smoking was really reduced among clients in these 6 programs. We also saw that asking about smoking, so the 5 A's starts with asking, increased from about 60 to 80%. This little notation means that it's a statistically significant difference. And availability, access of NRT or other pharmacotherapy. And now this is reported by the clients. So this is what the clients themselves are saying. Increased from 12.6% to almost 30%, also statistically significant. Another thing we saw, which I think is meaningful, but it wasn't statistically significant, but the proportion of staff and clients smoking together decreased from 28.3% here to 16.7%. I can say more about that in a minute. So I'm going to end my talk just with a couple of points about what I think programs and regulatory agencies might want to do in terms of tobacco cessation, behavioral health. At the program level, I think it's quite important for us to think about reducing staff smoking. Now, staff smoking rates will not be high in places like privately funded centers, hospital-based centers, medicalized settings, but it will be high, particularly for SUD. It will be high among persons in publicly funded SUD treatment among staff. I think that we can and should prohibit staff from smoking together with clients. Probably, I'll just make a bet that nobody on the webinar today has, recently had a smoke break with their physician, with their nurse practitioner, with their therapist, with their radiologist, with any healthcare provider. And yet, if you go into our publicly funded treatment programs, that's actually a pretty common occurrence. And I think we should adopt tobacco-free grounds, partly because, as Carrie said, the culture of smoking in many of our programs, and tobacco-free grounds is one way to begin to sort of break down that culture. It's not a perfect solution. It won't remove smoking, but it will reduce it, or at least our data says it will reduce it. I also think, though, sometimes we talk to our programs the way I'm talking to you now, and we say, well, programs should do this and programs should do that. But I think that our leadership institutions have to take some responsibility, not only to lay this on programs, but to say, incentivize programs. Are there ways that we can give them the training that they need, the access to medications that they need, or incentivize the payment structures in a way so that they have an incentive to provide this particular service, and then I think they would provide it. They can also mandate tobacco-free grounds, and we may talk more about that, but it's been done in a number of states. And I think in California, we're behind the curve in some ways, because at least we don't ask about tobacco status or smoking status at admission. We have a big statewide system. It reports on all of the clients coming into our SU, or substance use treatment system, but age, gender, ethnicity, but we don't ask. We don't even ask. So if you don't even ask the question about what is the tobacco use status in your population, you're not going to be effective in beginning to address it. So I'm going to end my comments there, and I think Catherine's our next speaker.
Thank you, Joe. Thanks, Carrie. Yes, I'm Catherine Saucedo. I'm the Deputy Director at the Smoking Cessation Leadership Center, also proud Director of the National Center of Excellence for Tobacco-Free Recovery. And as you can see here, this is a SAMHSA-funded project. We're really happy to be doing this work, promoting and facilities, helping them to adopt these tobacco-free policies, integrate cessation services into these treatment practices, and educate the masses, behavioral health, primary care, all around cessation. So what I've been asked to do is to kind of complement a little bit about what Joe was talking about, the work that we've been doing in California, the California Behavioral Health and Wellness Initiative. And this, I'll be taking kind of the model approach so you can see what we've done as the intervention and not getting as far into the weeds of what to do with an individual who smokes. And then I'm just going to touch upon at the end some Leadership Academy work that we're doing, states that are kind of doing wonderful work that I just want you to see the different areas that you can go to and set these goals for yourself, as well as touch upon a national partnership so you can see what national associations are doing as well to curb this epidemic. All right, so first up, we have the California Behavioral Health and Wellness Initiative. And note on this one, the operative word is wellness. This is really a initiative to help these facilities go tobacco-free, but we do not need to use those types of terms. We're really trying to avoid mandate, policy, tobacco control, but really trying to look at this as rehabilitation, wellness, trying to speak the language more of the behavioral health community. So the goal of the project, as Joe touched upon, is we have to, we're working to assist these cohorts, and there's up to 15 agencies within 4 cohorts, and we're helping them to adopt these tobacco-free policies, integrate cessation, as well as to encourage development of these wellness activities, the policies that are going to support that tobacco-free environment. At the same time, in conjunction with sort of honing in on these organizations and helping them, we're also doing statewide activities that include customized training, educational webinars, and the like, tools, all that to kind of till the soil, if you will, and get more interest for folks to join the cohorts. This is a statewide partnership. Many, many thanks to the California Tobacco Control that is spearheading this. They not only fund it, but they also play a partnership role. They issue the RFA, they establish those contracts, they set the eligibility with minimum 22 bed. We actually later reduced that to 15 just to get more folks in. And it's a $36,000 grant. It's over an 18-month period. And what makes this a little bit more unique as well is that the grant, it's not like saying, here's $36,000 to go tobacco free. It's more, here is all the services that you need to help you succeed working with SCLC and the like. And we're going to give you $36,000 on top of that. So really trying to reframe that. Our center works with them up, encouraging them to be tobacco free by 12 months, and then helping to sustain that afterwards for the rest of those months, the end of their time period. And they do not have to go tobacco free. They just have to take steps to strengthen or to go tobacco free, okay? And then this partnership also includes the Office of Problem Gambling at the state, nutrition education, obesity prevention. This is to have that wellness angle with free resources and all. And then Joe's team doing a really comprehensive evaluation. And one of the wonderful things about working with Joe and his team is that not only were we able to take some of the rubrics that they developed and have those be tools for these agencies to use to see how they're doing, but also this full comprehensive evaluation that Joe put on or put together, we could give back to those agencies, and that can be used almost like as a pilot study to show, wow, look what we were able to accomplish. How about we do this with all the other agencies, or how about we try this in the county? All right, so our role was really to be coaches for some training services. When it came to the actual cohorts and working with these agencies, we really tried to tailor the effort by creating this community of practice. We had an in-person back in the day, my heart be still me, We had in-person kickoff and site visits. We are now doing that virtually. One-on-one conference calls that will kind of address the specific needs of each of those agencies, and then the materials and such to go along with this, and then the social media national presence. This image off to the right here is just trying to show you how we really tried to simplify this process, really tried to make it seem doable in the eyes of these individuals. A lot of the times it's seen as this add-on and this huge burden. It's rocket science. We need experts. We can't do it unless we have all this money. And so we really tried to help them understand that it's a simple 10-step process, all under the umbrella of wellness. The state actually required that we have an advisory council for this project, and I just have to thank them for this. It's such a good idea. Just think if you have even a 1 year or a 5 year, to try and find the right folks who can help guide you through this process, who may have a different perspective to help influence the change along the way, but also to get their buy-in early on. So you can see we invited licensing complaints branch chief from the Substance Use Disorder Compliance Division onto this initiative. We had an expert, former director of CSAT, Center of Substance Abuse Treatment from SAMHSA. Carrie's team was on here. We had a county official. We even added 2 cohorts to this as the time went by. And then a unique angle. We're trying to get people to join what I call the Wellvolution, right? So rather than using those terms that I mentioned before about tobacco control and mandates and policy and restrictions, we really work with the agencies to speak their language and to promote these 8 dimensions of wellness that come from SAMHSA, really trying to show the whole recovery process. I talked a little bit about the community of practice, but this is just diving in a tiny bit further. We fondly call this the lunchroom, but what we're trying to do with those agencies is bring them together to help them learn from each other. And they're working to attack this barrier, working to attack this issue, and trying to solve this problem together. They also work to motivate each other, being at varying levels in the process. You can get somebody who's further along who can say, don't worry, it's okay, we've already done that. It's much better coming from a peer than coming from us as sort of these coaching experts telling them what to do. But all together working to help understand those linkages between wellness and tobacco control. We can't be the ones who are just, the overall overseers who understand it all, and really working together to do that has allowed the program to improve throughout the duration. This is just a sample of the types of questions or comments that we might get during a community of practice. So what are you proud of? Again, because of that continuum, you'll get somebody who is saying, wow, we've already reduced smoke breaks and we have our wellness breaks coming in and we've got our policy that's been approved. And then you'll have somebody who says, we're just proud to be staying afloat right now because of COVID, right? It's a challenging period. But they each get to help answer each other's questions. And then we kind of provide that platform as well as offer some solutions. You can see there, that's one of the houses building their planter boxes with the funding. And then a challenge may be that they're looking for feedback on, again, the continuum. Somebody is saying, we'd like to have ideas for more fun groups. Somebody mentioned, I think it was a book club, virtual book club. And then others are just asking about, the challenges of addressing these things during COVID. And again, hearing the optimistic voices of their peers help those that are feeling a little more pessimistic. It's a great solution. This agencies as well are required to do what we call personally and internally, we call it a case study, but for them, it's more like an agency highlight. They get the opportunity to dig deep and to say, I need a problem solved, or I need to, showcase something that we found to be so successful. So in this case, it could be, how can we use that helpline to integrate it into our workflow? Especially if phones are not allowed, right? Got to figure out solutions. And then as time goes by, these are great ideas for an e-newsletter that the state provides, so they get that attention. And then we also take that to a national level. And the agency actually has to write that article. We help them. A couple other bonuses that really helped move this along was we were able to broker bulk rate discounts with GSK for these agencies, combine that with the free nicotine patches that the state is offering, 2-week starter kits. They can get them within 24 hours, 48 at the most, even with COVID now. So that really has sustained that progress, and really trying to help them realize that the NRT should be a staple, almost as Tylenol is, right? To keep that on call. You heard from Joe about the statistics on this. I'm just saying that on the first cohort, sorry about that, hold on. On the first cohort, they're working with their wellness committee still. They're continuing to be engaged with not only the state nutrition and gambling, but they're also joining their subsequent cohorts and speaking to our teams. These are just some photos from actual organizations that we've worked with, taking, say, the smoking area and turning it into the ping pong space. They use the money to purchase that, creating a hydroponic system with that pond over there, and being able to, take the time out instead of smoking to not only learn that skill, but also see the fruits of your labor with the fruits and vegetables. And to the right, that's the yoga treatment that they're doing for folks who came out of correction facilities and are in treatment. Really, really good system. I talked a tiny bit about the statewide activities, but I do want to emphasize, I feel it's really important. We had behavioral health regional trainings. Again, it's trying to bust the myths and gain more interest. And then the CEUs was very important. We realized that the more you can provide those CEUs as a carrot, the more you're going to start to bring in people to be interested, and getting the certified alcohol and drug counselors was very, very helpful to get more folks interested. All right, so that is California in a nutshell. I'm going to briefly touch upon these state leadership academies, knowing that there are opportunities out there for anybody who's interested. And there are states that are doing good work. So cross-sector is the huge piece here. Behavioral health, working with tobacco control and others. These folks get together and create an action plan over the course of a day, 2 days. And here is just a quick sample so that you can see these states just been working for a year, potentially two, what they have managed to accomplish in such a short period of time. So shout out to California. Sorry about that. Shout out to California and to South Carolina. Already since January 1, 2020, all state supported community health centers, mental health centers are tobacco free. Alaska is now offering behavioral health services through their Quit line. We have prescribing reimbursement for pharmacists, and keep in mind, pharmacists are a critical role with behavioral health, with medications and such. So these are great progress. Standing orders for pharmacists to prescribe in Indiana, and they've already met twice since their first summit. Secured funding to go for facilities to go tobacco free, and in January of 2021, they will have their correctional facilities tobacco free. I love that last line, and offer NRT to offenders instead of tobacco products. Quick snapshot of other states that have been at it for a while. They're reaching their targets, surpassing it. You can see there's still a lot of work to go, but we're going in the right direction. And then finally, the National Partnership for Behavioral Health and Tobacco Use. And this is to show you that there's efforts going on at a national level. These associations, 27 of them, are working together to reduce the prevalence of smoking in the behavioral health field. We've got clinical organizations, government agencies, nonprofit and advocacy groups. Again, note the cross sector here: mental health, public health, tobacco control, and corporate working together as well. And each of them has made commitments to within their organization, as well as to work together to reduce the prevalence to 20 by 22. So 20% by 22. We're going down at 28.9 was the last check, but there is a lot of places to go, a lot of work to do. We can't do it without you. So just look at that last space there. Reducing prevalence to 20% means that we are going to be having several million fewer smokers, and many, many lives saved. And in closing, this is why we care, as well as the partners that we just outlined. But obviously, we know smokers are dying on average 10 years earlier. With behavioral health, it's upwards of 25 in various studies. 500,000 Americans are dying each year due to tobacco. And if you think about that, that's including half of those have a behavioral health condition. So 250,000 who have a behavioral health condition are dying from tobacco-related illness each year. As well as representing 25% of the population, we realize they are consuming 40% of those cigarettes sold. And that's the tobacco industry making quite a bit of money there. So it's an epidemic. It's a social justice issue, as the title of this webinar is this partnership, along with, we hope, all of you, is working towards increasing this health equity for this population that is obviously quite vulnerable to smoking. So I'm going to pass on, and no questions. We're moving on to our next speaker, which is Reba, who is also one of our Leadership Academy states. So go ahead, Reba.
Well, I'm happy to be here with you all today. I'm Reba Mathern-Jacobson, and I'm zooming in from the banks of the Red River in Minnesota. It's the traditional, ancestral, and contemporary home of Anishinaabe, Dakota, Lakota, and Nakota peoples. And I just want to start by acknowledging their contributions of Indigenous people, past and present, who live on and steward and protect this land that we're all standing on. I'm on staff with the American Lung Association, and my role is to address this disparity that people have been talking about. And I come to this work not as a tobacco control person, but as a behavioral health person. I'm a social worker. I did live and work with homeless families for over 11 years. And I've worked at a number of service settings where I saw really directly the impact of tobacco on the people that I worked with. So I'm happy to be working now on a systems change level approach to this work. It's already been mentioned that, the research is very clear and plentiful that in the mental health realm, if people are able to quit smoking, anxiety, depression, and stress go down. And it's just as clear within the addiction field that if people get treatment, they have a 25% greater chance of long-term abstinence or sobriety. So when we look at what's happening in Minnesota, we see that there's really a disjoint. This is according to the 2016 CDC MMWR report. And we see that just over half of programs in Minnesota screen their patients for tobacco use. And then that number goes down for how many offer tobacco treatment counseling. It goes down again for who offers NRT, and it goes down even lower for offering the other tobacco treatment medications. And then when we look at the issue of tobacco-free grounds, blue is the national average and red is where Minnesota is at. And while we would all like to see the national number higher, Minnesota is behind, particularly in the number of our SUD programs that have tobacco-free grounds. So to approach this, we really needed a lot of multidisciplinary and collaborative discussion and on an ongoing basis. So this work started in 2015 when the American Lung Association hosted a summit in partnership with the Center for Prevention at Blue Cross and Blue Shield of Minnesota, the Smoking Cessation Leadership Center, SAMHSA, and the CDC. And the purpose of the summit was to design an action plan for Minnesota to reduce tobacco use and addiction among individuals with mental illness and/or substance use disorders, and to create an environment of collaboration and integration. So what is now known as the Lung Mind Alliance has become that place in Minnesota where professionals from the fields of public health and tobacco control and prevention come together with professionals from the fields of mental health and substance use. And I'd say it was by the end of 2017 when we really started to hit our stride and settled into the way of being that has really worked for us. And so that means committees, cohorts, and convenings, which I'll talk more about. So today I'm going to focus on more of the nuts and bolts of how we function as the Lung Mind Alliance. I'm going to go through this slide backwards from what you see here. We want to reduce the disparity impact on this population. And our goals to get us to that point are, like has been mentioned, to increase the number of programs that offer tobacco treatment and to increase the number of treatment programs that have tobacco-free grounds policies. And to accomplish that, we have 3 action teams that work in various topical areas. And those action teams are comprised of coaches and members. They're supported by our advisory team and the ALA staff. These teams meet monthly, and anyone in the Lung Mind Alliance is welcome but not required to join an action team. And then the core partners take a role in coaching each of these action teams. And the topics of these teams has shifted over time. Our advisory team meets quarterly, and their tasks are to really hold the comprehensive vision of the Lung Mind Alliance and to cultivate connections and alignment around our strategies. And then besides myself, there are 3 other staff who use part of their positions to support the functionality of the Lung Mind Alliance by participating in the action teams, tending to the structure and logistics of event planning, and addressing other important areas such as communications and networking. So I mentioned that our core activities are committees, cohorts, and convenings, and actually we don't have committees. I thought the 3 C's sounded good together, but we actually have action teams. I'll talk a little bit about the reimbursement team first. We have 2 courses of action, one about how to make the best of our current situation, and the other is to change the systems to improve reimbursement in Minnesota. So on one hand, we're addressing the how-tos of getting reimbursed, which is possible. And we've identified organizations that have been successful in getting reimbursed for providing tobacco treatment. And now they're poised to help new organizations to do the same thing. And then on the other hand, we recognize that there are barriers and we're trying to address those, such as the limited roles of people who can get reimbursed, such as in Minnesota, a licensed addiction counselor can get paid to provide addiction treatment for everything but tobacco. And then another barrier being that organizations need a prescriber available to sign off on orders for tobacco treatment, and many organizations just don't have a prescriber. Our professional education action team has been developing resources for use in Minnesota. First, they developed these 3 handouts that address the myths and facts that are important in creating the culture change that we need to realize our goals. And then they developed a guidebook called Tips from the Field. So some of our partners, we were already familiar with some of the 101 toolkits out there about why to address tobacco in this population. And they wanted to develop this tool for some of the nuts and bolts about how to do that. And they laid out the process they used in their organizations so that others in Minnesota wouldn't have to start from scratch. And then this action team also just filled out our toolbox by developing an animated short that will gently nudge organizations to take up this work. And the professional ed team is in the process of developing a companion discussion guide for this animated short. Another core activity of the professional education has been offering training. We've been bringing Dr. Jill Williams to Minnesota for years for day-long trainings, which you can see in this promotion. We have now adapted to a webinar series due to COVID. We present at state conferences, and we've offered specialized training on motivational interviewing in tobacco and have a new training coming up regarding assessment. Our statewide policy partners action team is using a letter to cultivate and demonstrate ground level support that it really become the norm in Minnesota for treatment programs to integrate tobacco treatment and provide tobacco-free grounds. So what you can see here are some of the signatories, or who they are. And then on the back page, there's a growing list of Minnesota mental health and addiction treatment programs that have signed on in support. And some of the people signing this letter are fully accomplished in these areas, and others are somewhere along the process, but have signed to show that there's support that this happened on a statewide basis. So that was committees, and now I'm moving to cohorts. Our first cohort didn't start out as a cohort, but my predecessor was providing technical assistance to these 4 organizations. And they share a common service geography, all being in the heart of Minneapolis, St. Paul. And each organization had the same goals toward integrating tobacco treatment into their services and developing a tobacco-free grounds policy. And eventually it just made sense for them to meet together. And my highest respect goes out to these organizations for not seeing themselves as competitors, but really as collaborators. In this work, they did not set the same date for when they were going to go tobacco-free, and they each integrated tobacco treatment support in a way that was unique and fitting for their organization. But ultimately, their changes impact the 42,000 people that they serve every year and the combined 1,400 people on their staff. And these original cohort members are now key in the ongoing work of the Lung Mind Alliance. They help present at state conferences, they take leadership with our action teams and work on special projects. So we're now preparing for our third cohort, which will start in January. And I'm really excited about how our approach to a cohort has evolved. We actually have 2 members of the first cohort who are going to be co-facilitating this third cohort with me. And they'll be able to mentor new organizations as they each set their own goals for what they want to accomplish over the next 10 months of this cohort. We will have monthly meetings as the primary opportunity for organizations to build relationships with one another and support each other in their goals. Organizations will get monthly one-on-one coaching and TA calls with one of the facilitators. And then as part of this process, we'll help administer a staff readiness survey and provide staff education. So that was committees and cohorts. Our third core activity are our semi-annual convenings. I'm still on a little bit of a high since we had our December convening last week. And it was really an example of how we've been able to tap into the creativity of the group to offer an engaging convening that gets great reviews even when it's conducted over Zoom. I've put in our agenda here just to give you a glimpse of what we provide. At each convening, we like to have an opportunity for skill or knowledge development and an opportunity to do some work together or some planning toward the upcoming path for the Lung Mind Alliance. A central part of our live convenings was to build relationships and network, which of course culturally often happens around food. So for this convening, we sent everyone a gift card so that they could have breakfast delivered, and then we ate together in breakout rooms of 4 to 5 people. We had a keynote speaker from the National Council on Behavioral Health to address the connection between tobacco and COVID. And then we had also sent people some care packages in the mail before the meeting. And everyone got a little trophy keychain so they could share in receiving an award for excellence in community collaboration that we just got from our State Association of Addiction Professionals. And then among other things, people got popcorn to eat while we watched the newly produced animated short that I mentioned earlier. Our workshops served as our work time, and in closing, people entered 3 words that came to their mind about the Lung Mind Alliance, which generated this word cloud. And then since people sat with us engaged for 3 hours over a screen, we offered an optional breathing and movement exercise to help them transition into the rest of their day. And that's what our convening looked like last week. Thank you all for this opportunity to share, and a quick shout out to all the Minnesota folks on this call who have really contributed to the work of the Lung Mind Alliance. Cheers, I'll turn it over for Q&A.
Thank you, Reba, Joe, and Catherine. Those are great presentations. Before we get into the Q&A, I just want to remind all the attendees that we will have the slides and the recording available on our website. We'll be sending out the link within the next day or 2. So I think I'm going to start. Reba, I just saw a question here about how we can see, how can we see the animated short?
Well, we're just wrapping up our communications plan for its distribution. And so feel free to contact me if you're not already on our mailing list, and I'll make sure to share it with you. Put your name in the chat box. Okay,
great. Let's see. I'm going to go through we've got quite a few questions here. This one about the question comes in, how we make an effort to use treatment instead of cessation as it better reflects the degree of dependency involved with tobacco use disorder versus a habit to stop. Are there any thoughts or similar efforts on your end to adjust the language? And
You know, we
Joe?
talk about services. I mean, we talk, I don't know if I probably said cessation in my talk, but we talk a lot about treatment, about services, about tobacco-related services, which is, takes an emphasis off of cessation and quitting. But from my point of view, are they actually just getting services they need to try to quit?
Yeah, that's a really good point. You want to create equal access, right, to services. And so broadening it and making sure everybody gets access, I think is a nice angle as well.
Okay. Next question, do any of the states that were referenced that provide NRT, make those options available to anyone, or do they require them to meet certain criteria? The individual points out that his or her state offers free patches, but the guidelines are so strenuous, we really have a client in our area who actually qualifies. And our state tobacco grants do not fund NRT options.
Mm-hmm. I can speak to California, the California specific. They did everything they could to reduce those barriers and have done a phenomenal job. There has to be basic contraindications, just making sure there's not going to be any other medication that they're taking that the pharmacy angle with the doc, but overall they can get it in as quickly as 24 hours. So they've really done a phenomenal job. And then with other states, right, it's really trying to push the comprehensive cessation package of all 7 FDA approved medications, and one step at a time to make it as easy as possible for them to get it.
Okay, thank you. I had another question. This would go to Dr. Guydish, who said, Dr. Guydish said it is an 18-month program. How intensive is the program? 1 hour, once a month, or more intensive?
I'm gonna let Catherine answer that question because that's her intervention. But I will say that I think it's a really good question. So if you look at the literature, there are interventions that go anything from 4 or 5 individual webinars up to, I think what Catherine does is one of the most intensive, which is an 18-month intervention. And I do think it matters how long and how intensive the intervention is in terms of how well it works. But Catherine can speak to her intervention.
Right. So with ours, it was 1 call a month that was 30 minutes or more, depending on what the agency wanted, and that would be one-on-one. And then in addition, quarterly community of practice calls that were about an hour and a half with expert speakers joining, as well as that collaborative approach that I spoke of, where they could all interact. And other than that, webinars that were for the state, but that we invited all of those agencies to participate on that were about once a month as well.
Okay, thank you. Another question here. This might go to Catherine as well. I am a peer support specialist in North Carolina. How can I get more involved?
I love it. Well, visit tobaccofreerecovery.org. And if you're interested, the peer support specialists, I believe, are just an untapped resources. So kudos to you for asking that question. There are certified peer specialist programs now across the nation that are educating peers so that they can actually be interventionists as well and work to help their peers quit smoking and guide them in the direction of the right resources. There are wonderful resources that exist online that can already get you up and running to understand how to help somebody quit. At minimum, ask, advise, and refer, which is a wonderful resource to help double your efforts of helping somebody quit, especially if they refer to a quit line. So yeah, I would say for education purposes, if you're interested in learning, I would go to it's rxforchange.ucsf.edu, and there is an actual curriculum for peers on there to help them, to help you learn what you need to do to help people quit smoking.
Another question, and if anybody can answer it. Some organizations worry that if they implement a tobacco-free policy, they may lose employees. Is there data to show that implementing a tobacco-free policy does not cause this effect?
Yeah, that's a really good question. There is, as far as I'm aware, there's no data to show that this doesn't cause that effect. I will say, or at least nobody's written about it. Some people may know it. In the intervention, Catherine, that you did with the first 6 programs, we had the same amount of staff before and after tobacco-free grounds was implemented in those programs. And we heard nothing, we interviewed directors. We heard nothing from directors, for example. We surveyed staff. We heard nothing from directors or staff to suggest that, gee, staff are quitting because of this. But I think it's still a thoughtful question because, we do have high rates of smoking in the population. And, let's face it, that in the public sector, people are not really particularly that well paid. And so they might want to think of going elsewhere. But there's really no good data to show that that has occurred.
Right, and I'll add to that, if you combine it with the fear of attrition and the census and all of that, there is some information that came out of the NRI, National Research Institute, for the National Association of State Mental Health Program Directors, that indicated that it's really quite the opposite. I think there's a lot of fear out there, and it's just not fact-based. In addition, Philadelphia, we had Ryan Kaufman on maybe last month on one of our webinars, is doing some great work in the county there, and they are tracking this, and there has been no change. So you're going to get a lot of complaints at the beginning, but you have to remember what you're doing is saying, look, people, we're not telling you that you can't smoke. We're telling you that you can't smoke or that you have to quit smoking. We're just telling you can't smoke while you're working. And we're going to do everything that we can to keep you comfortable during that time by giving you patches or by helping you quit if you want to along the way. But, kind of reframing it like that, I think is part of the reason why we're not seeing that. So.
Okay, well, thank you. We are just about out of time. I do want to let the folks know who did not get their answers to their questions that we will be responding to you by email. And I want to thank the panelists here, Dr. Guydish, Catherine, Reba, and thank all of you for attending, and have a good rest of the day. Goodbye, everybody.
Thank you.
Bye.